All right, so thanks for coming, everyone. My name's Ashley Dupuis. I'm one of the OBGYNs that works at Spectrum Health Lakeland, and I'm at Bellanova Women's Health on Hollywood Road over at the big health park where all those offices are, kind of right on the first floor. And then I also have another office in Benton Harbor at Intercare. So I know this community, there's about, 9 OBGYNs in St. Joe, and so we do capture a lot of women from this area as well, because I know it's lacking. So tonight we are going to talk about menopause and just sort of the changes that can happen leading up to the years of menopause, and then some symptoms that you have once you're through menopause, and all the loveliness that comes with that. So we'll keep it pretty relaxed. We'll definitely take questions at the end. Stop me if anything is not clear during the presentation. But thanks for coming. So these pictures might look familiar, and that is why we are going to chat tonight. So I don't want you to have to walk around with a fan, with holding your head, with looking bright, but from sweat. So we'll try to show you some ways that you can prevent feeling those ways. So what is menopause? There's a lot of terms that I might use, and I'll try to stop and explain. For me, it's everyday language, but I know sometimes there are words you may have never heard before. So menopause is the permanent stopping of your periods after loss of ovarian activity. So this really cannot be determined until your periods have stopped for 12 months. There are some changes that take place in the few years before that. Usually on average about 4 years is that menopausal transition time. So things start happening, you start noticing changes in your body, changes in your periods, and so if you get to that point, you're pretty sure that your periods will fully stop in about 4 years, and that's just an average. But the median age of menopause is about 51 here in North America, so it is sort of a regional difference, varied by a few years, but generally 51. So anything less than age 40, if your period stop, is considered premature ovarian failure, premature menopause. I think the oldest lady that I had still having regular cycles was probably about 56. So I do not wish that upon any of you, but it does vary quite a bit. And then I'm going to touch on a little bit of anatomy, just because I'm going to use some of these terms later on, so I want you to know what I'm talking about. The vagina is the sort of bumpy, rugated part at the bottom, and that is where we put a speculum in during a female vaginal exam where we're collecting pap smears. So we place the speculum, we open it just a little bit, and we see the tip of the cervix when we do that. So this part right here is where we take a pap smear from. And that's really the only thing we can see when we put the speculum in. So sometimes I place the speculum and women say, "How do my ovaries look?" So sorry, ma'am, I cannot see your ovaries. And I'm not making, it's hard. I do this every day, so I take it for granted, but I cannot see any of this. Well, right here. I cannot see any of this when I look with a speculum. The only way we can actually see that is by putting a camera inside your belly, doing surgery, and looking that way. Welcome. So the uterus is this main part right here. It's a muscle, basically, and that is can expand quite a bit during pregnancy and becomes very thin when the baby's in there. But in its kind of non-pregnant state, it's sort of like a tiny little, we're always relating it to fruit, I don't know why, like a orange, basically, kind of firm down there behind your bladder. And then the fallopian tubes are these little tubes out to the side here, and that's when you're trying to achieve pregnancy, that's where sperm and egg meet, and that's really their only purpose. The ovaries are these white tissue right here, circles, and you have 2 ovaries generally, and those are kind of the main focus of the talk tonight, because those are what are producing your estrogen, and then your estrogen goes down. So it's kind of a loss of that ovarian activity is when the menopausal transition starts, and then when that activity completely ceases, that's when you're through menopause. So the hormones that decrease are estrogen and progesterone, And then there's a hormone called follicle stimulating hormone, or FSH is what we call it for short. And that one actually increases. So that can be tested by a blood draw. We don't generally use it for very many things unless it's really unclear if someone is through menopause. So if we draw that blood level, the FSH is really increased, then we can be sure that the woman is through menopause. But it's not a common, it's not something we just order all the time. A lot of women will come in just saying, like, can I get my hormones checked? Honestly, that doesn't really mean anything to us. You have a gazillion hormones in your body, and most of the time, unless you're trying to achieve pregnancy or you're having issues with infertility, those hormone checks are they're not helpful. So the most common symptoms when you're sort of starting this menopausal transition are the hot flashes, or some people call them hot flushes. They're really interchangeable terms. Vaginal dryness and menstrual irregularity. And that just means your periods start to get not regular. So what's a hot flash? A hot flash, you guys could probably tell me better than I can tell you, because I've never had a hot flash. But what I am not looking forward to when I'm approximately age 47 is the sudden sensation of heat. And usually it's chest, neck, and face. Some people feel it throughout their whole body, but generally it's kind of here up. And they usually last more like a minute, but they can last up to 5 minutes. And sometimes people have associated symptoms. They might feel nauseous, they might have chills, they might have heart palpitations where it feels like their heart's racing, some actual anxiety. And as you can imagine, or as you probably know, these can interfere with sleep. So how can we treat hot flashes? Well, the main treatment is systemic hormone replacement therapy. So that is using estrogen and progesterone to treat the severe hot flashes. There's other treatments that you might hear about or read about. Really, the data does not support those. So things like testosterone, injecting testosterone pellets under your skin, none of those things are good to use, in my opinion. There are compounded bioidentical hormone therapies that can be bought or made at a compounding pharmacy. I'll talk a little bit more about that later, but we also don't support that. And so there's a little bit of clarification, which I think I talk about in a couple of slides, but some people are on just estrogen, some people are on estrogen and progesterone for their systemic hormone replacement therapy. So I'll clarify that in a second here. The estrogens, there's a lot of different ways the estrogen is prepared. So there's pills, there's patches, there's sprays, there's even gels. And so these are a couple pictures of the different names of them. And there's even combinations of estrogen and progesterone together. So if you need to be on both, you don't necessarily have to take 2 pills. You just have to pay for it, you know? It's extra to get the good pill that has just both medications in one. Estrogen is not without fail. It does have some side effects. So things like breast tenderness, vaginal bleeding, bloating, and headaches are the most common. And all this sounds terrible, of course. Usually they're pretty self-limited. So they might happen for a week or 2 when you first start the medication, and then that should wear off. So similar to with menstrual cycles, you feel kind of these things around menstruation time. It's similar because it's estrogen. So progesterone or progestin is the other medication that we use to almost counteract estrogen inside the uterus. So estrogen goes all throughout your body, and there's other risks of estrogen I'll talk about in a second. So the progesterone actually acts to keep the lining inside of the uterus, which is the endometrium. So this kind of yellow part right here in the diagram is the endometrium. If you're on estrogen all by itself, it will eventually lead that endometrium to keep getting thicker and thicker and thicker and thicker. And that can put you at risk for endometrial or uterine cancer later on. So that's why we use the progesterone, is to keep that lining, that yellow area, thin. And so hyperplasia is a precancerous condition, and so it's not cancer yet, but it's something we don't want to happen. So the progesterone helps prevent that, which in turn helps prevent cancer. So the reason why some people are on estrogen only, that really should only be a woman who's had a hysterectomy, but they still have severe hot flashes that need to be treated. So if you've had a hysterectomy, you don't need progesterone because there's no endometrial lining there to protect. So, of course, there's been a lot of bad rap years and years ago from this big study that was done, the Women's Health Initiative, and there's many people that still pass down in their families, hormones are terrible, never be on hormones, they're the devil, basically. So that is not true. They've looked at the study a lot more closely. That study was not really using the women that we suggest have hormones. So a lot of the women they used in that study were older. They had a lot of risk for coronary heart disease, stroke, things like that already, and so they should never be on hormones. So there's a subset of women with severe hot flashes. They're less than 60 years old. They don't have any comorbidities that you can't use estrogen for, and they don't have other risk factors for stroke, heart disease, and those are the women that we suggest use hormones. So they're not for everyone. I can't give all of you hormones and just be okay with it. I need to make sure I know your history first. So that is a big part of it. But blood clots, breast cancer, those are things that, if you're, of course I recommend mammograms for everyone over age 40. However, especially if you're on estrogen, I won't even refill your prescription for you if you don't have a mammogram in the last year. That is something that needs to be monitored. And of course, breast cancer is 1 in 8 women, so it is a common cancer to have already. And that's why we use estrogen and systemic hormone replacement therapy when we need to, but it's something that should always be used for the shortest duration possible at the lowest effective dose. So we don't just throw it at women at a high dose and say, be on this until you die. That is not how it works. You're on it for a short amount of time, and then we do a trial off, see how those hot flashes are. Are they still there? Are they better now? Can we do every other day dosing? How can we get the dose to be a little bit lower? So I mentioned compounded bioidentical hormones. These are plant-derived hormones that are chemically and structurally similar to hormones that our own body produces. So that sounds great. There are actually some FDA-approved bioidentical hormones, and those are the ones that we use in the office every day for hormone replacement therapy. What we don't use are the compounded bioidenticals, I guess I don't suggest them. I have patients that use them, and we've talked about the risks, but the compounded medications, our issue with them is that the dose is not consistent necessarily within each with each dose, whether it's a cream or a pill. Because it's compounded, sometimes there's a buildup of the medication in one pill and then less of the actual active ingredient in the next pill. And so it's not consistent, and that can lead to just irregular bleeding, some of the other side effects that we talked about, when a consistent dose wouldn't do that. And so the FDA-approved ones, at least that you're getting the same dose every single day. So if you start bleeding, I'm not going to blame it on the medication. I'm going to look into it and make sure there's nothing else going on. So there are some non-hormonal treatments for hot flashes. Like I said, not all women can have estrogen. So you're not just totally out of luck. There are a couple other things. And most of them are off-label uses, but they're very common uses. So Paxil, which is an antidepressant, the FDA approved it at a low dose of 7.5 milligrams to be used for hot flashes alone. Sometimes I use Paxil at the normal dose for an antidepressant instead. I just try to make sure I tell the patients, this is technically off-label. I use it every day. So that being said, a lot of the medications people use for different ailments are actually really kind of off-label uses. Clonidine and gabapentin are a couple others that we try sometimes. So none of the kind of natural products, complementary botanicals are FDA approved. They're not really tested for safety. So things like phytoestrogens, herbal supplements, even lifestyle modifications, which I will touch on because I think they can help. The data does not necessarily show that they're a gold standard for treatment. So the real gold standard is the systemic hormone replacement therapy. That being said, a lot of people like to use these kinds of things, or at least try them before they come to me. And so I will touch on those. Phytoestrogens they're the plant-derived sources of estrogen. So there's a huge list here, but and some of them, beer. Am I going to prescribe you beer for your hot flashes? No. And in another screen, you'll see that beer or any alcohol, caffeine, those can actually be triggers for hot flashes. So yes, we hear the one red glass of wine, whatever, there's pluses and minuses to everything. So I'm not necessarily promoting that, just to be clear. But yeah, different nuts, fruits, veggies, soy products, of course, herbs, grains, those all have estrogen in them. So you're probably eating some foods with estrogen oftentimes. So the people that really wanted to crank up their estrogen in their foods would try to focus on these. The herbal remedies are common for people to try before they come in too. So they have not been supported by the data, but black cohosh, ginseng, St. John's wort, ginkgo biloba are some of the ones that people will try. Vitamin E has been looked at to cause one less hot flash a day. So that's 800 international units per day of vitamin E. To me, that doesn't seem significant, but the lifestyle modifications that haven't really been proven, but I think they can help to some degree, are some things that seem quite obvious. So layering your clothes, making sure you all, like I do, have a sweater on so you can take it off and have a tank top on underneath. Making sure that you kind of keep a cooler temperature. Maybe you keep your house at 68 degrees. Well, maybe you need to back it down to 66 when you're in the perimenopausal transition. Consuming cool drinks, having your bottle of water filled up with ice cubes all day long can help. And then, like I said, avoiding alcohol, caffeine, and maybe those aren't triggers for you, but for some people they are. It is sort of an experiment to see what triggers your hot flashes. I find that anxiety actually triggers hot flashes for a lot of women. A lot of women will come into their appointment, physically get there, 2 minutes later, they're like, yeah, I'm having one right now. And I'm like, yeah, because you're nervous. You just came into the office, so just anxiety, being in a fight with someone, anything like that can trigger a hot flash too. This chili pad sleep system I've heard wonderful things about, so if you have an extra $500 laying around, that is something to try. So that's what I'll talk about with hot flashes, and that was just one component of things that can change during the perimenopausal transition. So the next thing we'll talk about is our just vaginal symptoms in general. So vaginal atrophy is the fancy term for what happens during perimenopause and during menopause. So vaginal atrophy is the thinning down of the tissue. And it says vaginal tissue here on the slide. It's really all the tissue associated with the vulva and the vagina. So the vulva is everything that's sort of external, the things you can see. You actually can't see the vagina from the outside. So the labia minora, the labia majora, those are part of the vulva. So those get thin as well. And so a lot of women, I truly think it's more than this 10 to 40%, will report vaginal symptoms. And sort of the further away you get from menopause, the more vaginal symptoms you have. There can be dryness, there can be discharge, and it's not an infectious discharge, it's from the thin tissue, basically. There can be itching associated with this dry, thin tissue, which all this leads to painful intercourse. And the thinning of the tissue just makes it not only painful, but easier to tear during sex or even without sex, increased risk of urinary tract infections, and then the actual vagina itself gets more narrow. If you remember on that first slide of the anatomy, the vagina is what we call rugated, which means the sides are sort of bumpy, and that actually allows expansion of the vagina. Like during sex or during labor and delivery, the vagina has a pretty large capacity. And so when not exposed to estrogen for a long time, And then you're also not having sex as often. The estrogen is down, the tissue isn't as lubricated. That area, the vagina, becomes more narrow. So if women are not having a lot of hot flashes, but they are having these vaginal symptoms, I think treating with like the oral estrogen, the oral progesterone is overkill. You can really just treat the local symptoms. So the local therapy is still an estrogen, but it's actually a vaginal, and I usually say cream, but it actually comes in many different formulations. So there's creams, there's rings, there's tablets that all contain estrogen, but instead of a tablet that goes in your mouth, you actually place the tablet vaginally. So I know it might sound weird for people, but it is, in my opinion, much less risky to treat with vaginal estrogen if you don't really need it systemically. It does not carry the same risks as taking an oral estrogen pill. So we don't actually, how I talked so long about using the progesterone to counteract the inside lining of the uterus getting thick, you actually don't need to do that if you're using just local vaginal estrogen. So of course there's the people we talked about who cannot have estrogen, and that includes people with hormone-sensitive breast cancer. So we would definitely try different medications. Even the vaginal estrogen, I try other things first, and I would really make sure to get the approval of their oncologist before I used even vaginal estrogen in that subset of people with the history of the breast cancer. So these are a couple of our non-hormonal options, and they're actually found over the counter. The Reverie beads, I actually need to check on as far as if they're at the stores. I know you can get them on Amazon. I did look up that, but I'm not sure if they're at like Meijer and Walgreens yet. So the historic one is Replens, and these are both considered vaginal moisturizers. So unlike vaginal lubricants, they're not meant to be used just to make sex more comfortable. They're actually meant to be used to trap moisture and provide long-term relief. And you do kind of do a loading where you use it every day for the first week or two, and then you can back down to every few days. But the Replens is more like a gel, and the Reverie are beads. So they're newer, but they're beads that you place vaginally. So usually I have people try those first before I try them on vaginal estrogen cream. They're cheaper and less risky because it's just no estrogen at all. All right, so that was vaginal symptoms. So next we will move on to period changes. And this seems to be the most distressing one because usually women are used to their monthly cycle. Comes 28 days for the last 30 years, and then all of a sudden things change. What we hope is that there's lengthening of the intermenstrual interval. So what that means is the time between periods. So wouldn't it be great if you just, you turned 47, 48, and you started skipping a month, or you started skipping 2 months? That's the way, the textbooks say it should go. A lot of times it happens almost in the opposite way, where people have, I've been bleeding for a month straight. And so sometimes we have to do further testing to make sure, this isn't like hyperplasia or cancer. And a lot of times it's not. It's part of this perimenopausal transition, but it presents with really heavy bleeding instead of the spacing out. So once you hit that 12 months of no bleeding, that's when we say, okay, you should never bleed again. And that is blanket statement. Once you hit 12 months, you should never, ever, ever bleed again. And do not come back to me and say, well, I just thought it was a period. Honey, you are 75. It is not a period. So if you take one thing home tonight, take that home. Because, if we catch endometrial cancer early on, which presents with postmenopausal bleeding, it is extremely curable. It is usually cured by hysterectomy, no chemo, no radiation, most of the time. So please don't ever let yourself have postmenopausal bleeding for a long period of time. Okay, side note. So this, like we've said before, the period changes kind of precede the stopping of periods. So a lot of times it's not for the full 3 to 4 years that you might notice the vaginal symptoms or the hot flashes, but it's more like most of the time the last year, sometimes 2 years. Sleep disturbances are oftentimes due to the other things that we've talked about, especially the hot flashes. So a lot of people will have them just at nighttime. Some people are, unfortunate enough to have them during the day and during the night. So we'll talk about a couple sleep tricks here. Some of them seem obvious and some of them seem not doable. I'm still going to go through my list, but I know you're probably kind of laughing internally at me. So sleep as long as necessary. When you feel rested, get out of bed. So some people that might, you may wake up at 4:30 every day and you might feel rested. And you might say, I didn't get my 8 hours. Well, a lot of times as you age, you don't actually need as much sleep as you did before. Maintain a regular sleep schedule. And this is hard because most of us want to what on the weekends? Sleep in on the weekends. It might actually help you if you have trouble with sleeping to really try to keep that consistent. Try not to force sleep. So I can't even, try not to force it. If you're not tired, maybe read for a while, maybe do something else for a while, but not stare at your phone or the TV. But try not to force it if you're not tired. Avoiding caffeinated beverages after lunch. So I got my caffeinated tea right here. I'm not following the rules, but that really does help if you have a problem with sleep. So it seems so early in the day, really afternoon, but yeah, it does help. So drink your 1-2 cups of tea, coffee in the morning, and then try to be done with it. Concentrate on your water with all your ice cubes. Avoiding alcohol in the afternoon or evening, which is hard because most of us can't drink in the morning, which I'm not suggesting either. So I guess that means avoiding alcohol altogether. I'm just going to move on from that. So avoiding nicotine, especially in the evening. Again, I want you to avoid nicotine at all times. But there's that. If you are a smoker, then try to cut it off a little bit earlier in the nighttime because it is a stimulant. Adjust the bedroom to decrease light stimuli. So hopefully you don't have to be as fanatical as my husband who covers every tiny little light in the room. But for him it helps. And keeping a dark room can be helpful for some people. Alternatively, my mom sleeps with her TV blaring the entire night. I can't talk her out of it. I wish she would try it for a while because I truly think it would help if you don't have that. So you hear a lot of people say, I can't sleep unless my TV's on. I don't know. I don't believe it. So radio off, lights off, TV off, cell phone down, face down, maybe not even in your room. A lot of people grab their phone in the middle of the night like, oh, what time is it? Oh, geez, it's 5:30, I have to get up soon. That's not helpful. Maybe just fall back asleep. Who knows? Maybe you have 6 hours left. It's not helpful to know what time it is. So right before bed, also, you probably do the same thing. My husband and I do. We're looking at our phones, catching up on our Facebook, our Instagram, our emails, looking at pictures of our kids. So we should not do that. It's not helpful to your brain to realize, hey, it's nighttime, dark time. Resolving concerns or worries before bed. So, of course, this is a good adage for anyone, but probably people told you advice, maybe if you got married, hey, don't go to bed mad. There is something to it, not just for your marriage, but just for your brain in general. If there's something bothering you, I often tell people to write things down. I think it's helpful to have a little pad of paper by your bed, and if you're like me, you think of all the things you need to do right when you're trying to sleep. So that's when you can just reach over, write it down, and that kind of gets it out of your brain. Exercising regularly can help, but not right before bed, not the 4 to 5 hours before bed. I don't think, honestly, this one is big of a deal. I think the benefit of exercise, if your only time that you're available to exercise is in the evenings, I still think it's probably worth it. If it's the last thing you haven't tried, and then try not exercising then. But any exercise is better than no exercise. And then, of course, trying to avoid daytime naps so you're more tired in the evening. Depression is another common kind of perimenopausal or menopausal condition. There's a lot of Well, first of all of these things we've talked about are sort of just depressing in general. So whether or not the actual neurotransmitters in your brain have changed, which they do, your thoughts and feelings about the things that we've talked about can also be depressing. Why aren't I having any sex anymore? Why is sex painful? Why is my bleeding crazy? When is this going to stop? Why do I feel like I need to lay on the linoleum floor in Meijer to get my hot flash to go away? They can be pretty distressing. So I think people overlook things like meditation, relaxation, kind of think it's hokey pokey, but honestly, I think it can be really helpful. There's a lot of apps that have 3-minute, 5-minute meditations on them. And meditation, I think notoriously people think you're doing it wrong if your mind wanders. No, that's literally what it is. Your mind wanders and you just bring it back to your breath. And then it wanders again and then you bring it back. And every 5 seconds it's wandering. And that's how it's supposed to be. You're not meditating the wrong way. You don't have to think about any certain thing. It's just kind of bringing your thoughts back to your breath. And even if you do that for 3-5 minutes, I think it just kind of helps settle things down. So I think right before bed or right when you wake up in the morning or both is really helpful. And of course, things like counseling, avoiding unnecessary conflicts, or people who anger you. So that's just, if you have certain family members or certain friends that you seem like you're always just leave the situation angry, maybe you're better off without that friend. Sexual function, we touched on a little bit, but the decreased blood flow to the vulva and the vagina is really significant. So it is, unfortunately, kind of a use it or lose it phenomenon. And I'm not saying like your vagina goes away. I'm not trying to be funny, but it really does become more narrow. It becomes less lubricated. And so I think it's really important for blood flow to be increased to that area every so often. So it is use it or lose it. And I know for some of you it might be scary to think about. You may be married or in a relationship where, there's been pain with sex, which makes you not want to have sex. And so you're at that path where you haven't had sex for a while now. Well, how do you get back into that? It can be awkward. And so a lot of it starts with just going back to just hanging out. You don't have to feel like, we need to put sex on the schedule tonight. I went to this talk, Dr. Dupuis told me I'm using it or I'm losing it, and so I got to use it. You don't have to make it awkward at first. So even just hanging out. Sometimes we get in the situation where we're almost like, people living in an apartment together, co-parenting, instead of like, hey, we used to have fun together. Let's try to schedule some date nights. Let's do something like that. So non-sexual contact first, and then once you're engaged more emotionally, intellectually, then that usually leads to physically. So it is sort of a continuum. Cognitive changes, I don't have a lot to say about this, except that some of the other things I've talked about for helping with the other symptoms, and I'll talk about weight gain next, but the changes that you can make with your diet and exercise really can be helpful for cognitive changes too. But it is a real thing. Many people report increased memory loss around this time. So I'm going to focus a little bit more on weight gain than I used to, because I see it so prevalently in my office, and it usually is mid-40s when people start really telling me. And I've only been a doctor for 4 years, and I'm not quite to that age yet. Give me a few years. But I am not looking forward to this time because of what my patients tell me. So I'm trying to spread the word. I know there's a couple of younger women here. If there's anything you can do now to be in your best health when you're becoming your mid-40s, now is the time to do it. And I'm not saying it's all a lost cause if you're a little bit older, but the people who are mid-40s and above, it is extremely normal to gain weight during this time because of all the hormone changes. Even if you kept everything else exactly the same, I'm still eating the same food, I'm doing my exact same exercise for the last 20 years, you will gain weight in your mid-40s. So Exercise, I obviously promote exercise. It's great for your cardiovascular health. It should not be used as a primary weight loss tool, though. It's not sustainable to go out and exercise for 2 hours a day for the rest of your life. That's not going to happen. Whether you're just not healthy enough anymore or you finally become sick of it, you'll just gain the weight back. So I definitely recommend exercising 20, 30 minutes almost every day of the week, but not necessarily for weight loss. Will you maybe lose weight? Sure, but that's not why you're doing it. So I've been kind of listening and reading a lot of things the last couple of years, and so I included a couple book titles here and podcast titles that I recommend. And so a couple of the books are The Obesity Code, and I guess I should have clarified, I am not in any way attached to any of these, so I have no financial disclosures with this presentation. The Obesity Code is a book by Dr. Jason Fung, and he's a nephrologist, that's a kidney doctor, and so he sees a lot of people with diabetes, and so he promotes a low-carb, high healthy fat diet, no sugar, and this all sounds very idealistic. I'm not looking for anyone to be 100%. There's no way that people can just, never eat sugar again. I'm not suggesting that. But if we can cut one little thing back at a time and be good, I shouldn't say that, not eat sugar 90% of the time and have your one day of week where you have a cookie or something, that is probably way better than what you're doing now. And processed foods that we eat have tons of added sugar into them. Undo It is another book by Dr. Dean Ornish. He's been around for a long time. You may recognize his name, but he is a longtime whole food plant-based supporter. And so there's lots of diets that you hear about, the keto diet, the paleo diet, the whatever diet. So there's really no diet per se that is better than the others, but the whole food plant-based lifestyle, I'm going to call it, is really the only one that's been around for so long that it has had enough time to be proven beneficial and been proven to really decrease your risk of developing heart disease, developing diabetes, and thinking about a whole food plant-based diet is really hard for most of us, especially when we hear in the background the keto diet, which is a lot of meat, and then a whole food plant-based diet's the opposite of that. So I completely feel you. There's a lot of conflicting things out there. Keto diets are kind of a newer diet. In the last few years, people have been talking about keto. There is no long-term data on keto to say that it's safe later on. You will lose weight with keto, hands down. So if you've done it, cool, you will lose weight with it. However, if you don't sustain it, you start eating your carbs again, you'll gain the weight back for sure. So people do have to kind of mess around with what's best for them, not looking for 100% all the time because it's not sustainable necessarily, but doing the best you can with one little change at a time so it's not overwhelming. Maybe it's a month at a time of changes, and that's fine. If we're not looking to progress towards anything, then we're going backwards. And so what you don't want is just to stay steady or to go backwards. So as long as you're trying something a little bit at a time, you're doing the right thing. A few different podcasts. So I've never listened to a podcast until like 2 years ago. I didn't even know what a podcast was. Now I love them, and I do not drive anywhere without listening to a podcast. So there's an app on your phone. I have an iPhone, and so it's a purple app that just says podcasts. And it's a great way. There's a search engine on it. So, and I don't mind if you guys want take pictures of the slides to remember the names or whatnot. But these three have been really helpful. The Life Coach School podcast right here is pretty intense, and she does talk a lot about kind of weight loss, but I have found it most helpful. I think she's on episode 271. She's been doing this for years. I think I'm on episode 160, so I haven't even listened to all of them. And not to be dramatic, but it truly can change your life, I would say. that really does sound dramatic, I know, but the way that I interact with people, the way that I think about certain situations has completely changed. So hers is not just about weight loss at all. It's not about menopause. So why am I even bringing it up since this is a menopause talk? I have just found it so helpful that I want everyone to know about it. There's topics on anxiety, topics on boundaries. How do you set boundaries with different people? Say your mom, that's a hard relationship sometimes to set boundaries between. I mean, any topic you can think of, she has a podcast on it, and I think even if you listen to the first couple, you'll be hooked. They're truly amazing. Sort of mind-blowing ideas of ways to think about things that you would have never considered before. The Weight Loss for Foodies podcast is more about weight loss, so it's Sherry Broder does that one, and they're quick podcasts, which is nice. They're usually 10 or 15 minutes. And some of them you can change the speed on the podcast. So I do them at like 1.5 speed. So you can get through them pretty quickly. Nutrition Rounds is a newer one. And this Dr. Bellardo is a cardiologist, and she has a whole food, plant-based clinic that she runs. So she has patients that she kind of converts from whatever diet they're doing, whatever lifestyle they're doing. And these people are sick people. They might be on the transplant list. They might have severe coronary artery disease. And she is in no way against, if someone needs a bypass or a heart stent. Those things are definitely needed. But she works in the background too. A stent fixes something really acutely. It does not change your life. If you go back to eating the exact same way before your stent, you're going to have another heart attack. So those three are my recent podcasts that I really like. So as I kind of alluded to, healthy lifestyle is one change at a time. It's decreasing dairy maybe 1 month, decreasing meat, decreasing sugar. So those are the things you want to decrease. Things you want to increase are things like whole grains, vegetables, legumes. And like I said, you don't have to be perfect, but sometimes people are really surprised at how good they feel by especially dairy. If you cut out dairy for a month, just try it. I know it sounds crazy. Just try it. I think it sounds crazy too, but you might notice like, oh, I thought this is how you felt after you ate a meal. You just feel really full and bloated, and well, of course, I just ate. You might not, and it doesn't mean, I'm not saying you're lactose intolerant or whatnot. Kind of our bodies have lost the ability to sort of process milk in a way that's beneficial for us. So this is also a little dramatic, but we're not baby cows. So do we necessarily need milk? Are we trying to grow from a little calf to a mama calf in a year? No, like we're not. And so trying different milks, I just made my kids start drinking cashew milk instead of dairy milk. So now they have to specify, can I have some cow's milk? Can I have some? No, sorry. And it's fine. You get used to the taste. As I've alluded to, eating healthy is one of the best things you can do, not only for weight loss, but for actual menopause symptoms. So that's why I put it in this talk, is not only do I think many people struggle with weight gain in their 40s and 50s, it can actually help with the symptoms of especially hot flashes, the brain fog, the fatigue, the inflammation in your joints. And I wanted to add, I actually just learned about this a couple months, the spectrumhealth.org website has this really awesome culinary institute that I had no idea existed until recently. So I put some snapshots of what the website looks like, because it does take a few clicks to get there. But if you just go to spectrumhealth.org, and I'll kind of talk slowly in case you want to write this down or take a picture of it, but you click on the patient care tab, and then the nutrition tab, and then the culinary medicine tab. You have to sign up, and then you receive an email a couple minutes later, and that has the link to, I guess I should go forward, to all the recipes that I'll show in a second. So and part of the reason the hospital is involved in this is because obviously we have tons of patients at the hospital who are coming in for being sick, or they're coming in for outpatient surgery, and we want them to be in the best health possible if you're having surgery. So not only can these help to lose weight, but they can just fuel your body. So It's hard to think about every time you eat something, what is the purpose of that? Is it fueling your body or is it hurting your body? Because it's doing one or the other. And another good kind of little thing I learned from, I think, the Brooke Castillo podcast was many of us grew up with a scarcity mentality around eating. Clear your plate. There's children in Africa who are starving. And there are children in Africa who are starving, and I'm not trying to say anything about that. What I am saying is that you truly are not helping anyone by eating that food. You are not saving a child in Africa. You are essentially treating your body as a wastebasket, because if you have extra food on your plate, you're either putting it in the trash can, and it's not going to Africa, or you're putting it in your body. And I'm really, truly not trying to be facetious. You are treating your body as a trash can when you overeat like that. So, and during the Depression, during times when families did not have any money, it was hard because you feel like my parents worked hard for this food, I should eat it all. A lot of people are not in that situation anymore. And so I would just urge you to think about that the next time you have food on your plate. Are you eating it really because you're hungry, or you just feel bad? You're at a restaurant, you feel bad. They'll think I didn't like it. Truly, they don't care. So this is kind of what the website looks like. You push this green sign up button. You fill in this short little form, first name, last name, an email address, and then you can pick if you're interested in any ongoing events or information. And then this is an example of some of the recipes, and a lot of them are whole food, plant-based. There are some fish recipes in there too. So it's kind of a cool way to get started. A lot of people eat, their meat, their potatoes, and their vegetables, so it's really hard to think about, well, if I don't eat my meat, what am I eating? And so there's a lot of ways that you can sort of alter the things in your house that really still taste really good and your family will still like. And this is kind of my last slide before we'll take questions, but basically we talked a lot about weight tonight, and that has to do with menopause because that's a lot of times when the weight starts coming on. So I just wanted to urge you guys to calculate your BMI just so you know it. This is kind of a side note, but every time you go to the hospital, or not the hospital, but any clinic really, and you have a doctor's appointment, it's usually automatically calculated. All we need is your height and your weight. And so there's many little calculators if you Google BMI and you just plug in how tall you are and your weight, and then it will calculate for you. And I think being overweight or obese is so prevalent in our community that it's become normal. And I'm not getting down on anyone. I'm in the overweight category myself. It is just one of those things that I think we should be aware of. There's some women who don't think that they are overweight or that they're obese, yet their BMI might be 35 or 40. They could be the smallest person in their family, and so they might be really proud of themselves, and that's great, but it's also good to sort of have a reality check sometimes. Most of us are probably overweight or obese, and part of it is the culture that we live in. Everything's so busy, we go out to eat all the time, but I think it's nice to at least know where you're starting, and then you can sort of work. Every lower BMI point is a huge win. So, and I know I look at my patients' BMIs every single time they come to the office, and I really try to comment on them, even if they went down, in a good way I meant. So even if they go down 0.5, I really try to give a lot of encouraging feedback, because I know to drop a 0.5 BMI, that took a ton of hard work. So that doesn't need to go unnoticed for them. They really need encouragement, because that will spur them on to keep doing what they're doing. So I will take any questions now.